Good morning, everybody. Thank you so much for joining today. We have a really wonderful presenter talking about another very important topic. As usual, before we get into that, we'll start with our updates. Dr. Collins will start us off as always.
All right. Can everybody see?
Yep. Thank you.
Okay. So just very brief update on the COVID numbers. Oh, there we go. Basically, the numbers continue to move in the right direction. This is a curve of our census at the Stanford hospitals in Palo Alto. You can see numbers of COVID positive continue to come down. Looking at the numbers in the chart, as of yesterday, there were 13 COVID positive and an additional, or I should say COVID on isolation, and an additional 28 of what we would say COVID cleared. The numbers are now such that we've actually been able to phase out surge teams both on the wards and in the ICU. So hopefully we can keep doing the right things for this trend to continue. And then the only other thing, I wasn't going to necessarily spend a ton of time looking through all these numbers, the percentages we've looked at before, and they're relatively similar. But I did think it was interesting to note that this is now data for an entire year. You can see the breakdown there. And again, the other numbers here we've looked at before. So I wanted to thank again everybody. I have the folks who helped this week, but also just through that year, bringing all this data that we can share to keep us updated and keep us informed and take the best care of our patients we can. So thanks.
Wonderful. As always, thank you, Dr. Collins, for those updates. And then our final updater this morning, Dr. Ben Pinsky, to talk about variants and anything from our lab. Thanks so much for being with us, Ben.
Thank you. And good morning, everyone. I'll show you all a familiar slide now from the last few weeks, looking at the variants with the decreased number of decreased positivity rate. Variant genotyping has slowed down a bit. Good news here, we have not seen any of the Brazil P1 variant, which has been in the news of late. We have not identified any additional South Africa variants. We have found a few presumptive UK and Brazil P2. And as you can see, the West Coast variant remains, or California variant remains very prevalent, with approximately 37% of our positives being of this strain. And that's the variant update for this week. And I'm happy to take any questions in the chat.
Again, thank you so much, Dr. Pinsky, for being with us and for those updates. Great to hear that it hasn't, the variants haven't been a big part so far, and thanks for keeping us updated on that. As we mentioned last month, we had our first kind of themed month honoring Black History Month, and both Dr. Dunn and Dr. Caceres are Associate Chairs for Diversity Medicine, who are on the panel as well with us today. You may not see them, but they're here to answer questions if needed. We talked about that we will have a rolling year talking about keeping the topic of inclusion medicine, our Inclusion 2020 theme. And that continues exactly today when our next Grand Rounds covers that topic as well. And I'm really excited to have Dr. Deidre Cruz, who Dr. Chertow will introduce in just a moment. Before we do that, I wanted to also introduce Dr. Stephanie Harmon, who you may have seen a letter from Dr. Harrington. Created a new chair, and she's our Associate Chair for Women in Medicine. And many of you know, Monday was International Women's Day. This month is Women in History Month, and we want to make sure we're honoring all the different themes that we have going on throughout the year as we started this the last month. And so Dr. Harmon's going to talk briefly about a couple of things related to that. So I'll have her come over, and I'll have some slides for her. And Steph, if you have
the classic mute, classic Zoom errors. So I was just saying, thank you so much, Errol, for that welcome. Good morning, everyone. March is indeed Women's History Month, and we will be spotlighting Stanford women in science and medicine. You can actually hide the slide, Errol, for now. The Women's History Month actually began as a movement in Sonoma County, actually here in California. And then President Jimmy Carter ultimately made a presidential proclamation in 1980 for Women's History Week in March, and then it evolved into a month. And so As I mentioned, we will be spotlighting Stanford women in science and medicine. And this week we're spotlighting 2 faculty within the School of Medicine. And you may have seen that in the Department of Medicine newsletter that went out yesterday. Dr. Sharon Hunt and Dr. Odette Harris. So Dr. Hunt is a professor in the Division of Cardiology in our very own Department of Medicine and a pioneer in cardiac transplantation. She was one of only 7 women in her medical school class here at Stanford. Dr. Odette Harris is a professor in the Department of Neurosurgery and a leader in traumatic brain injury and gender differences in the TBI. And she is the first African-American professor of neurosurgery in the United States. And we have links to videos and more about these amazing Stanford women in the Department of Medicine newsletter. Next, I want to call your attention to 2 events coming up in the next week. The first, and there'll be a slide you'll see is the Women Lift Health panel, which will be happening on March 8th, International Women's Day. Errol, if you could show that first slide. So again, March 8th being International Women's Day. Women Lift Health is an organization founded by our very own Dr. Michelle Berry, who's our Senior Associate Dean for Global Health and the Director of our Center for Innovation in Global Health. And this will be a remarkable panel moderated by Paul Costello on advancing equitable leadership. The second event that I wanted to highlight is hosted by our Stanford University Faculty Women's Forum. It's on the next slide, on faculty salary transparency and equity. And this panel will happen on March 10th at 3 p.m. And while this Faculty Women's Forum event will not be specific to the School of Medicine, it will include Marcia Cohen, who is our own Senior Associate Dean for Finance and Operations in the School of Medicine, as well as Brian Hoffmeister, who's the Executive Director of Faculty Compensation, also in the medical school. And they will not only be talking about salary, but other forms of compensation, including bonuses, retention bonuses, et cetera. And the event will be followed by a School of Medicine specific discussion sponsored by the Office of Faculty Development and Diversity. And so with that, I would just encourage folks to stay tuned to our Department of Medicine newsletter and our Twitter feed for more on women's history at Stanford. And looking ahead, we will be highlighting women in medicine throughout the year, as well as for Women in Medicine Month in September. Okay, back to you, Errol. Thanks so much.
Dr. Harmon, thanks so much for that. And we're really looking forward to hearing from you regularly throughout the year. And please continue to give us feedback on how we can best update you on all topics, including honoring gender diversity. Well, before we introduce our update, our new presenter today, I just want to mention next week we have Dr. Shanna Felt talking about the WellND update, Stanford efforts to promote physician wellness. And the week after that, we have Steph Glickman, who is the Senior Vice President and Chief Health Officer of Blue Shield California. We actually scheduled him months ago, and with Blue Shield coming in charge of vaccine rollout, we'll be really excited to hear from him. And then followed by that, we have Dr. Aaron Segal really joining us from Israel, presenting as well. Well, it was just a little over a month ago, Dr. Lafayette, I see your message this morning. You brought to our attention that March is also National Kidney Month. And thanks so much for bringing that to our attention. Throughout the year, we will always try to honor and celebrate various holidays themes as we can. So I appreciate anybody's feedback to make sure we're doing that. It's a new thing we really started doing this past year, and we're going to continue to do that, whether it's presenters or updates like Dr. Harmon just mentioned, to make sure we're honoring different things. To introduce our presenter today, Dr. Deidre Cruz, I will ask Dr. Chertow, who is now our Vice Chair of Fellowship Medicine, and also, of course, all you know, used to be our Division Chief of Nephrology. He's been close friends with Dr. Cruz for many years, and it's great to have him introduce Dr. Cruz. So, Dr. Chertow, thanks for being with us.
Thank you, Errol. Congratulations, Dr. Harmon. It's really my honor to introduce Dr. Cruz, who's a personal friend and a personal hero of mine. For those of you who haven't met Dr. Cruz, she is a graduate of the University of Virginia and St. Louis University School of Medicine. She did her residency and fellowship training in nephrology at Johns Hopkins, where she also received a master's degree in public health and epidemiology. She's currently full professor of medicine and is the Associate Director of Research Development at the Johns Hopkins Center for Health Equity, very relevant to the topic she'll be presenting today. She's also a core faculty member at the Welsh Center for Prevention, one of the strongest epidemiology groups in the country, if not the strongest. She's a national and global leader in health disparities research and one of the few nephrologists truly active in community-based participatory research, and is a renowned teacher, mentor, clinician, an investigator, and a personal friend, and a great singer. And I'm delighted to introduce her. She'll be speaking on structural competence, a pathway to kidney health equity. And thank you, Dr. Cruz.
Thank you, Dr. Shertel, for that lovely introduction. I was following right along until you mentioned the singing part. What you didn't share is that my singing career began and ended with accompanying you in your songwriting during our fun times during study section together. So thank you so much for that. I'm really thrilled to be with you all today. I'm going to try to share my screen, hopefully successfully there. I'm really thrilled to be with you all today. I certainly enjoyed the visit that I had there in person, I guess probably 5 years ago now, and certainly hope to get back to visit in person and in the future. And so, as was said, I'm going to share with you all today a bit on structural competence and how it may be a pathway to kidney health equity, and I think to health equity even more broadly. And so these are my disclosures. None of them are relevant to the talk today. So in terms of an objective, I've actually, in this time, I've really just had one objective, and that is to try to seize upon this moment in history that all of us are living through, to take the opportunity to highlight disparities in kidney disease, to name structural inequities and specifically structural racism as a root cause of some of these disparities. And finally, to try to galvanize our broader medical community towards structurally competent care and also research that will move us closer to achieving health equity. And so I listened intently to the updates that were being provided with respect to the pandemic. It sounds like great progress is being made there, as is the case around many areas around the country. But I need not remind you all that we have really been living through this in this past year, what many have referred to as dual pandemics, in that we've been dealing with the COVID-19 pandemic as well as these recent incidents of very visible high-profile acts of racism. And these dual pandemics, if you will, have levied a real disproportionate set of consequences to communities of color. And so in this piece, authored with my colleague, Dr. Tangela Purnell, we tried to highlight some of the consequences to these communities of color, including disproportionate experiences of grief. We know, for example, for Black Americans that 1 in 750 Black Americans have actually died during the pandemic. And so that means that for those that have that are still alive, they are all essentially most likely to know someone who has passed away. There has been food scarcity that's been disproportionately experienced by communities of color. Many have lost employment. There's been this heightened fear of institutions that's been brought about by really a breaking in many ways of the social contract that communities of color and really all of us have with or share with several of our institutions, including the justice system. And so when we've seen these months ago, especially when we saw these very high-profile acts of violence against Black individuals who were unarmed, this has certainly led and spilled over fear of institutions that are felt by these communities of color. So fear of not just the justice system, but other institutions, including the healthcare institution more broadly. There has been, and I think this has been highlighted very recently, increasing fear of violence and harassment that's been experienced by certain groups, including Asian Americans who have been harassed in the setting of really in the COVID-19 pandemic, and misinformation and xenophobia kind of related to messaging that has come about in the pandemic. And certainly there's also been care delays that have been experienced in many cases disproportionately in communities of color. And so all of these are certainly things that we are experiencing. And so specifically in kidney disease, this time that we're living through is really adding on to known very profound disparities that we see in kidney disease. And indeed it is now National Kidney Month. And so I'm particularly delighted to be here with you all to be able to shed light on these disparities. So we know in the United States that Black or African Americans make up around 13% of the US population, but comprise a third of those individuals with kidney failure. We also know that Hispanic individuals and Native Americans are twice as likely as Caucasians to develop kidney failure, and that people with low incomes are twice as likely as those with higher incomes to also progress and develop kidney failure. And then when it comes to the optimal treatment for advanced kidney disease or kidney failure, that being kidney transplantation, what we see is that African Americans, Hispanics, and Asian Americans are less likely to receive living donor kidney transplants than are white individuals. And this figure on the right really highlights just the really profound and pervasive nature of disparities when it comes to kidney disease. And so in this time, there has been increased attention to racism as a root cause of particularly some of the health disparities that we see, but also in some of the other disparities we see more broadly, including, as I alluded to, in our justice system. This model that was published by Dr. David Williams and colleagues, I think is a helpful one in helping us to think about how racism may relate to what we see with respect to health. And so here they highlight the three kind of key types of racism. The first being cultural racism, which is the embedding of the inferiority of Black people and other non-whites into belief systems, images, and norms of the larger culture that can then lead to negative beliefs, such as stereotypes, and also can lead to prejudice. The second type that they highlight of racism is institutional or structural racism. And these are societal structures or different policies that actually reduce access of socially stigmatized groups to desirable opportunities and resources. And then finally, the third that they highlight is individual level racism. And these are experiences of differential treatment, such as discrimination, that is directed at stigmatized racial groups. And here this is being done by both social institutions and also individuals. So when we look at health, just to call out something that I think could serve as an example of what we may see when we think about individual discrimination. If a person has either themselves experienced unfair treatment that they view as being as a result of their race or their ethnic background, what we can see in healthcare is that they may then have a lot of hesitancy about seeking out healthcare. They may be expecting that that the care that they will receive will not be as high quality as others may receive. Certainly, we are seeing this show up quite a bit when it comes to the COVID-19 vaccines that are becoming available. And many people have highlighted that some of the hesitancy that we see among communities of color may be due to historical incidences of unfair treatment that have taken place. We think about things like the Tuskegee experiment of untreated syphilis, for example. But many of us have argued that really it's present day experiences that individuals can turn to that either they themselves have experienced or their friends or family members have experienced that really make people question whether certain new therapies may be of benefit to them. And also they may question whether those advanced therapies may be accessible to them. And so this really really, I think, serves as an example currently in terms of how experiences of individual level discrimination or racism can show up in terms of how people react to the healthcare system. And so this is an understudied area, this idea of individual level racism or perceived discrimination. So it's a very understudied area in kidney disease. But my colleagues and I were able to provide one of the first reports of this association. Here we use data from the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study, or HANDLES study, which is a Baltimore-based cohort study. We looked at self-reported perceived racial and perceived gender discrimination across 5 distinct situations that are highlighted here. We also used a general measure of experience of discrimination in this study as well. And just to give you kind of the major findings, what we found was that among white women, a high level of reports of experience of discrimination was associated with a lower level of baseline kidney function in this study. And then among African American women, both perceived racial and gender discrimination were linked to a lower level of kidney function after 5 years of follow-up. In a separate study, the Jackson Heart study, some investigators used data there to look at the relationship between a number of different factors surrounding discrimination and trust in healthcare providers, and how that then related to the practice of seeking routine medical care. Here they focused on over 3,000 participants who either already had chronic kidney disease or had a key clinical risk factor for kidney disease, including either diabetes or hypertension. They looked at a number of these different factors, and in their sort of multivariable adjustment, what they found was that having a low level of trust in healthcare providers, experiencing high levels of psychosocial stress, and having high daily reports of discrimination, or the experience of discrimination, were associated with then having kind of these low care-seeking behaviors, or being less likely to seek out routine medical care. And so turning now to residential segregation, which is such a key and impactful form of institutional or structural racism, and is really where we'll spend much of the balance of our time together this morning. A key practice that really has led to what we see today in terms of residential segregation is the practice of redlining. And this is, I should say, a discriminatory practice by which banks and other institutions in a position to make loans to different individuals in communities would restrict the areas that they would make those loans to, and largely they would deny, through this process, deny loans made to a number of different communities of color, including those where largely inhabited by Black Americans. They also had a similar practice with respect to religious minorities, including Jewish individuals. And so I took the liberty of pulling a redlining map of San Francisco that you'll see on the left-hand side here. This is from the 1930s. On the far left is kind of the more original map, and then you'll see it sort of drawn out on the one there in the middle. And those areas that were highlighted in red, again, were those that were deemed to be considered hazardous for these banks to make loans to. On the right-hand side, I'm highlighting the redlining map from the 1930s from Baltimore. And what I want to note is that Baltimore actually, at that time, was considered a leader, if you will, in this practice of redlining. In fact, at the turn of the 20th century, Baltimore was already practicing this process, and several cities around the country kind of modeled themselves after what was being done in Baltimore. And I'm highlighting here this redlined area, and the star represents Johns Hopkins Hospital, which, as you heard, is where I work. And so if you'll remember that, try to keep in mind this area here in Baltimore. And then I want to highlight for you that what we see in Baltimore is that even 5 miles of difference, even 5 miles of distance makes a world of difference for health. What we see in this community in the northern part of the city, that's an area called Roland Park, is that around 80% of the inhabitants are white. The median household income is fairly substantial for this area. There's a low level of unemployment, low homicide rate, a pretty good life expectancy at 83 years, and a fairly low death rate when it comes to heart disease. And if we contrast that with an area further south in the city, the Madison or East End, what we see is more than 90% of the residents are Black or African American, and this community has a third of the income level as Roland Park, with high unemployment rates, high homicide rates, and a nearly 20-year lower life expectancy, including with a very high death rate from heart disease. And you'll recall that this is the same community that was highlighted in that redlining map, really, I think, demonstrating that the effects of redlining from now nearly 100 years ago have really carried forward into what we see today with respect to health disparities. And so in kidney disease, what we see in terms of the opportunities that communities have really does appear to make a big difference in terms of outcomes. We know that we, for those of us in nephrology, are increasingly caring for patients that, particularly when we think about our dialysis patients, who are coming from poverty-stricken communities. So if we look to the right-hand side of this figure here, we can see in this study, they highlighted that around a couple of decades ago, the US population was comprised of around 11% of individuals who were living in communities that had high rates of poverty, with more than 20% of the residents living at below the federal poverty line. In the United States, particularly around that time, that poverty limit or poverty level was considered around $25,000 a year for a family of 4. And so in these communities, more than 20% of those households were experiencing that level of income. And then we see that there has been an increase in sort of the more recent period at 12.5%, again, in the general population. Whereas in the dialysis population, looking at people newly starting dialysis, what we see is that a third of those individuals are coming from these communities, again, characterized by high amounts of poverty. One thing that redlining certainly also contributes to is the availability of suitable housing in these communities. And this issue of homelessness and housing instability is one that, again, is understudied in kidney disease, but something through work with my colleague, Dr. Tessa Novick, we have tried to look at. Here, using, again, data from the Handle study, we took a look at around 350 participants in the study who had chronic kidney disease already, and we looked to see what proportion of them were experiencing housing instability. And what we found was that when using these questions, are you able to afford a suitable home for you and your family? Or have you had difficulties making rent or mortgage payments? What we found is that 38% of those individuals, again, with CKD, did report that they were experiencing these problems, indicating housing instability. Additionally, in this overall sample, around a quarter of the participants reported having postponed their medical care, even in a time when they felt they needed to seek medical care. And so when we examined in different statistical models the relationship between housing instability and postponing medical care, what we found was there was this independent association between those two factors, again, among people with chronic kidney disease, really highlighting that for people already with kidney disease, if they are experiencing housing instability, they may delay care seeking we would certainly hypothesize due to their dealing with other challenges that they're dealing with in their life, in part related to their instability with their housing. Another important topic, particularly in kidney disease, is nutrition. We often, when we're caring for individuals either with even early chronic kidney disease or with advanced disease, including those on dialysis, will make recommendations with regard to the dietary patterns that they follow. And certainly in order to follow a healthful dietary pattern, it sort of requires a number of factors. One, there has to be availability of grocery stores for which to purchase those types of foods. Transportation needs to be in place to be able to get to those stores. There needs to be availability of healthy options and less sort of fast food restaurants in such a community in order to sort of facilitate and promote the purchasing of healthy foods. We know that a healthy diet is closely tied to exercise and those habits. And so living in an area where there are safe and accessible places to exercise is important for the overall nutritional picture for people with kidney disease. And then finally, individual purchasing power. So just having the money to be able to purchase food is really important when we think about nutrition and chronic kidney disease. And we know that a number of these factors really relate to this idea of residential segregation and as an example of structural racism, in that there are going to be communities that don't have these things in place. In some of our work to try to understand the types of barriers that African Americans, particularly those who have low incomes, may face if they want to try to prevent themselves from developing kidney disease, we did a focus group or qualitative research study where we recruited individuals who had a first-degree family member with end-stage kidney disease, and we asked them a number of questions around food access and what they thought would need to be put into place in order to facilitate them not developing kidney failure as their family member had. And so a number of the themes that emerged included that healthy foods were expensive and weren't available in certain neighborhoods. One participant said, and what we have in our neighborhoods and most low-income neighborhoods is fast food restaurants everywhere. You hardly see a farmer's market or fresh produce stand or even fresh produce in the supermarket. And as soon as you walk in the market, the first thing you see is cakes, cookies, chips, cereal with loads of sugar. They also highlighted that unhealthy foods are more convenient to prepare or to access, and that unhealthy dietary practices had been a lifelong habit that they thought would be quite difficult to break. Another barrier, really kind of to layer on top of what we see in terms of residential segregation and then availability of healthy foods being limited in some communities of color and low-income communities in particular, is this issue of food insecurity, which, as you are likely familiar, is defined as the limited or uncertain ability to acquire nutritionally adequate and safe foods in socially acceptable ways. What we see in the United States is that non-Hispanic Black individuals and Hispanic individuals bear a substantially higher burden of food insecurity than non-Hispanic whites, for example. We see that there tends to be spikes in food insecurity during periods of economic downturn in this country, including during the Great Recession. And certainly we are also seeing that in the setting of the COVID-19 pandemic. Here, this is some data from Feeding America, where they list the 10 highest rates of projected food insecurity from 2020 compared to 2018. And these are states with the highest rates of food insecurity. Just to highlight Texas, which we know has dealt very recently with a really significant snowstorm that left to power outages and water outages. In that state, we see that they are one of these top 10 states when it comes to food insecurity as well, and with an expected 18.6% of the population to the tune of 5.3 million households expected to be experiencing food insecurity during this time. And so in kidney disease, what we tried to look at was the relationship between food insecurity and progression to end-stage kidney disease. And this is work with my colleague, Dr. Tanushree Banerjee, who is nearby you all at UC San Francisco. We use data here from the National Health and Nutrition Examination Survey, or NHANES, that was then linked to Medicare data. We examined the different questions that are asked in the context of NHANES that around food security, that include questions like, in the past 12 months, did you have to skip meals or reduce the size of a meal because there wasn't enough money to buy food? And what we found was that those individuals who were experiencing food insecurity as assessed through this questionnaire were more likely to progress to end-stage kidney disease than those individuals who had food security. When we examined further and looked at a number of different potential confounders of that relationship between food insecurity and progression of chronic kidney disease, we were somewhat excited to find that when we included nutritional factors into the model here, that we were at least able to statistically explain some of that relationship. And here nutritional factors were total caloric intake, body mass index, and dietary acid load, which for the nephrologists tuned in will know that certain foods, including those primarily coming from animal sources, present more acid for the kidneys to handle. And there's a body of literature, some of which my colleagues and I have contributed to, telling us that that can be injurious to the kidneys and also can predict progression of kidney disease. And so when we accounted for those factors, we were able to, again, statistically at least, explain away some of this relationship. And so taking all those findings really as a backdrop, what we're now doing is conducting a clinical trial to try to overcome some of these structural barriers to access to healthy foods, as well as some of these behavioral barriers, such as that lifelong habit piece that was highlighted in our qualitative study. And we're conducting a study called the 5+ Nuts and Beans for Kidneys trial, which builds upon a successful pilot study that was for people with hypertension. And our current study is a 12-month community-based dietary intervention study in 150 low-income African-American participants who have both hypertension and albuminuria. And what we're doing is we're testing whether providing nutritional advice to adopt a dietary approaches to stop hypertension, or DASH-like dietary pattern, plus $30 per week worth of potassium-rich foods, so these fruits, vegetables, nuts, and beans that are provided by a local grocer, will lead to a reduction in urinary albumin excretion and also improvements in blood pressure. Ours is a community-based participatory research study wherein we have a number of different partners that we work with that are highlighted here, including ShopRite, which is our grocer partner that provides the weekly foods to that intervention group. And so I think certainly as we look at health disparities, including in kidney disease, and note that there are these preventable differences in burden of disease that can be experienced by socially disadvantaged populations, and we think about how to move us to kidney health equity, it's where we would see that every person is afforded the opportunity to attain their full health potential, and no one is disadvantaged from achieving this because of their social position or other socially determined circumstances. It's going to require that I think we re-examine really a number of our different approaches that we take. And so in this piece in the Journal of Clinical Investigation, Dr. Lisa Cooper and I tried to highlight a number of different approaches really under these two themes. One being relationship-centered care, which really is one where we should all, in my view, be trying to become more self-aware of our own biases and how that may be showing up in the care that we deliver to patients. We should be trying to work on increasing our participatory communication style with patients so that we're inviting them to share their perspectives. This type of care requires a respect for individuals on really in all kind of domains, and it is enhanced by shared values and identities. There's a body of literature, Dr. Cooper has led much of this, we're really highlighting that when a clinician and their patient share in identities, including race and ethnicity, that the quality of their communication is better, as are the outcomes that really stem from that that care relationship. And so the relationship-centered care piece is really important, and will help us to really enhance the trustworthiness, the level of trustworthiness that we have in healthcare and also in research. Structural competency is one that may be less familiar to each of you, in that this is one that I think in this time where we have had this heightened awareness of health inequities and health disparities and also social injustices, this approach really does call upon us to enhance that and also to develop our partnerships with community stakeholders. It really requires organizational transparency in this work, and increased funding for work such as in health disparities that are helping us to develop means for addressing these challenges. And it does require diverse participation as well as diverse leadership in healthcare. And so this move that many are kind of suggesting from a place of cultural competency, which we may be much more familiar with, to one of structural competence, really requires that we have the ability to understand that health disparities are driven by forces at institutional and societal levels, and that we should take these factors into account when we're managing our patients and also when we're conducting research. It broadens these elements of cultural competency to include a much more rigorous recognition of the role of social determinants of health. And it also recognizes that these structural factors, it recognizes that the structural factors that shape patients also have an effect on health professionals as well. And so our colleagues are also in many cases experiencing a number of these challenges, these discriminatory experiences that I alluded to in earlier slides. And importantly, it requires that we re-articulate a number of the things that we have maybe in the past deemed as being cultural or cultural differences between groups, racial and ethnic groups, for example, into structural terms. And so I highlighted an example earlier when in thinking about the vaccine hesitancy, for example, that's been talked about a lot in the literature and in the lay press as well. It really requires structural competency, requires that we consider what factors at a structural level actually may be contributing to the hesitancy that we may see, which I would argue is really well-earned mistrust in many cases. And so that's one example. This approach does also require that we have structural humility. So the idea that we acknowledge that we don't know everything about what patients that we may be seeking to support have experienced. And this really calls upon us to invite them to share those experiences with us so that we can be better partners in their care. And then finally, it really requires that we each use our power and our privilege in our own settings to advocate for those groups that are socially disadvantaged and socially marginalized. And so to summarize, we are certainly at an inflection point for both racial injustice and also health disparities in this country. And I would say that that includes in the space of kidney disease. Racism is a root cause of many of these observed racial disparities. And we certainly have an opportunity to enhance our structural competence in each of our settings towards achieving health equity. And so I will end there, and I look forward to your questions.
Great, Dr. Cruz, thank you so much for that really insightful presentation. And we have questions coming up right now, so I want to get right into that. So thank you so much. We'll start with, let's see, Dr. Leibowitz had a question that came up earliest, and he asked, and I'll put it live here, the grocery store availability variable has always mystified me. In San Francisco's Chinatown, where poverty seems to be rampant, Almost every other store along Stockton Street is a grocery store with low prices. In the Mission District, it has been, until recently, Latinx and high poverty. There are also a large number of grocery stores. In both communities, the stores appear to be small mom and pop stores, yet we always hear about the lack of stores in high poverty African-American neighborhoods. Does anyone know why this is?
Yeah, and I without being familiar as much with those areas in San Francisco, what I would suggest, and the small mom and pop stores are wonderful, and I would be curious to understand better kind of what's stocked there in terms of the types of foods. One thing that has been seen in a number of studies that have looked at this question of access to healthy foods is not just the sort of the presence of some food, but also whether these are fruits and vegetables, these are whole grains, low fat dairy foods, these types of healthier options are if they are being provided in these smaller stores. We do see across the country though, and this has been documented in a number of settings, that there is less availability of sort of full service supermarkets in a number of communities of color across the country. And those tend to be the stores that stock those healthier options. But I wouldn't be able to kind of comment without knowing particularly those stores. I wouldn't be able to comment on that. I will say that in those communities where they're predominantly inhabited by Hispanic or Latinx individuals, and also those predominantly inhabited by African Americans, we see much of what kind of I was alluding to earlier in terms of that limited availability.
Thank you. Next question up here, Beth asked, do you know if there is any data on routine social work assessment and intervention for at-risk outpatients and inpatients to improve access, for instance, for food? In my opinion, Stanford has insufficient number of social workers. There is a positive impact with specific social work assessments and interventions. This might be a way for Stanford to support our greater communities?
Yeah, thank you for that. I know that that in a number of different health systems, social workers do help with this, as do, when it comes to food and specific, as do dietitians, at least in terms of doing these health assessments. Certainly the degree to which they are then connecting those patients to services is variable. One of the challenges is that food insecurity, for example, is not necessarily assessed in every health system. I didn't have time to cover it today, but there was a systematic review that was conducted a couple of years back that looked at what different health systems around the country do to assess food insecurity, and then how they, where they document it, and in many cases it was actually in the electronic health record, and then what do they do with that information. And in some cases, what they did with that information was to have social workers connect those patients to those services. In some other settings, they use community health workers as well for a similar purpose, to connect people to services, and to be able to even go to the homes in some cases of those patients to help kind of assess what the barriers are.
Great, thank you. I want to pull our next question from one of our panelists, Dr. Harmon.
Thanks, Errol. Thank you so much, Dr. Cruz. One of the questions on one of the last slides you had was this concept of moving cultural to structural, and you had mentioned kind of the work of moving from cultural to structural humility. And I was wondering if you could say more about what does that structural humility look like, right? I think about institutions and policy. Mm-hmm. Thank you.
Yeah, thank you. Yeah, I would. So what I would say around that is, again, an understanding of the role that these factors play in how they show up in terms of, when we think about in the clinical setting, and how they show up in terms of in individuals, patients, for example, in ability to engage in their own self-care, right? And that the humility portion of it would be that we shouldn't make sort of assumptions about, for example, when we label a person as being non-compliant or even non-adherent, that we shouldn't we shouldn't make assumptions about why that is, right? We sometimes articulate the reasons for non-adherence or non-engagement as being, oh, well, that group of people culturally don't do this thing, right? Or they culturally aren't trusting of the healthcare system. And that structural humility really would argue that we should consider those factors, those structural factors that may be at play to explain why they're not kind of following those types of recommendations that we may have.
Thank you.
I hope that helps.
Thanks so much, Dr. Harmon. Deanna Grenier-Mullins asks, how can we increase traction in eliminating the race-based modifier in the estimated GFR calculations?
So thanks for that question. So I actually am serving on, for those, I think I'm guessing everyone's familiar with this. So in kidney disease, we have in our GFR estimating equations, currently there is a Black coefficient that is included, a Black race coefficient that is included in the reporting of GFR. I'm currently serving on the task force that's addressing this issue. That's a joint task force between the American Society of Nephrology and the National Kidney Foundation, and we expect to have recommendations about this to come out in the next few months. And so I would say that to me that's the traction. So it's that there is definitely an ongoing national effort around reassessing that practice.
Thank you very much. Dr. Weinberg's next question, could you discuss the NIMBY, not in my backyardism, as a successor to redlining? Can health effects of communities adjacent to others with various not in my backyard laws be measured? Question.
Yes, thank you for that question. So I would definitely say, and this is why often when talking about redlining, we'll say that was kind of the legal practice again until I think it was 1968, the Fair Housing Act, that addressed this, at least from a legal standpoint. But there is still this, as you phrase it, the not in my backyardism that continues to practice, continues to sort of be there. There are a number of different states and locales and cities that are looking at residential segregation, sort of studying it, to your question. And examining how they line up with health outcomes. I mean, similar to what I shared with you all today in terms of looking at what we see in Baltimore. As far as laws surrounding it, I think there is room for us to advocate for those sorts of things, perhaps that will be informed by what is gleaned from those locales that are in some cases just newly beginning to look at the effects of residential segregation.
Great. Moving on, Dr. Garcia asks, it seems that most of the data you presented are on urban communities. Can you comment on urban-rural disparities and how structural vulnerability is experienced?
Thank you. Yeah, I did mostly present on urban communities, in part because that's where I work and have conducted most of my work. For sure, there are significant racial, ethnic, and socioeconomic disparities, including in kidney disease, that are experienced by rural communities. In that case, we see particular challenges when it comes to both access to health care, certainly as a challenge, as well as to healthy food as well. And so in some of what I highlighted that we see in urban communities is also the case, particularly with respect to access to full service supermarkets in a number of rural communities. Less of that has been done in the kidney disease space, but in some other areas, I think about some literature in diabetes, for example, that has looked at that. So some of these same things show up in terms of in rural communities as well.
Excellent, thank you. Dr. Rompf asks, how does ingesting more potassium-rich foods decrease albumin excretion in the urine?
So thank you for that. I may have to come back to do a full talk on that, but so what we know is through and you may be familiar, I would sort of start by saying you may be familiar with the DASH diet, the dietary approaches to stop hypertension dietary pattern. And so what we know is those high potassium foods actually kind of down-regulate excretion of hormones, actually, that really will promote sort of stimulation of increases in blood pressure. So there's a blood pressure effect that happens in terms of from those high potassium foods. In addition to that, there's actually some literature that some hormones, thinking of things like angiotensin, that can have more direct impact on the kidneys. They also get downregulated in the setting of these a more basic milieu, a more basic environment in the kidneys, and that is another mechanism through which that has been shown that albumin excretion is reduced. So, but thank you for that question.
Thank you for that answer. That's interesting to know. And we would love to have you back to talk more about the pathophys. Dr. Cruz, you mentioned earlier if it's okay still to just go a few minutes more to try to catch more questions.
Sure.
Great. Thank you so much. Dr. Poon asks, is there any data comparing similar economic level neighborhoods of different ethnic background?
So if I'm understanding that question correctly, are you saying that if it sort of, do we see, maybe if I rephrase it a little bit, like when we look at, for example, Black Americans compared to white Americans who live in a similar level of socioeconomic advantage, do we, for example, see similar health outcomes? There is a body of literature looking at kind of different health outcomes that certainly argues that many of those health outcome differences, those disparities, are less apparent in those cases. Many of those racial disparities are less apparent when at similar kind of socioeconomic levels in neighborhoods. The Handel study, which I shared some data from, is an example of a study where we have the ability to look at that because of the way that the participants were sampled. And so we do see for some health outcomes that neighborhood level sort of socioeconomic status is more of a driver than any other factors that may be differentially experienced by racial and ethnic groups. And so the short answer to your question is yes. And we do see that when in similar socioeconomic circumstances, we do see a little bit more similar outcomes between I can tell you between Black and white individuals, particularly at the high levels of income. To contrast, though, importantly, at low levels of socioeconomic status, I can tell you in kidney disease, we see an amplification of disparity. So meaning that African Americans with low incomes actually have much worse outcomes than even white individuals who have low incomes, right? And so we actually see that racial disparity amplified at those low levels of income.
Dr. Cruz, we have two questions left. I'll see if I can get to those before we close out today, if that's okay with you. Tessa Solomon asks, it seems increasingly structural competence should include addressing the political power or lack thereof among underserved communities. Mm-hmm. What might that look like?
Yeah, thank you for that. I think, so in terms of political power, I think it really begins with even just the ability to vote and not having there be suppression of the vote in these communities, greater representation in kind of elected offices, I think would certainly go a long way. I think as we get to that place, those of us that are in positions where we may have more influence should be advocating for those groups.
Excellent. And one of my favorite people, Sona Tharani, who does a lot of work addressing equity at Stanford and outside of Stanford, asks, would you please share your view on reparations via healthcare systems?
So yeah, that's an interesting one. So as far as, should, I guess to phrase the question, should healthcare systems be in some way paying reparations or providing reparations to these socially marginalized groups? I think it's not something I've kind of specifically given a lot of thought to, but I do think that health systems do have a responsibility, particularly for the communities that they serve, to address some of these inequities that I highlighted today. So if you think about things like if we think about things like access to healthy foods in some of these communities, like I was mentioning today, health systems are often kind of one of the largest employers in the communities that they're in. I know that's the case for us in Baltimore. And so there is an opportunity, I think, and responsibility for those systems to be advocating for greater access for that community that they are taking care of. And so I do think in that way that they could provide those sorts of reparations.
Thanks, Dr. Cruz. As we close out, and Randy Stanford, thank you. Your comment is noted. I'd like to ask Dr. Dunn, as I introduced you earlier, our associate chair, one of our associate chairs for diversity and inclusion. Tamara had a comment.
Hi, Dr. Cruz. Thank you so much for that wonderful talk. And, we've been talking a lot about the EGFR situation, and that's really just based in racial stereotypes. And, I just wonder, why do we move so slowly in medicine? I mean, Dr. Seuss can stop production of 6 books just like that because there are, racially insensitive images and the like in them. And I just really wonder why we move so slowly in medicine, right? We've had this racial reckoning in our country. And why can we not just say, okay, we realize this is based in racism and stereotypes. Let's do away with it right now.
Mm-hmm. Yeah, I mean, I think, and I saw in your comment, you were particularly alluding to the
EGFR.
Sure. Okay.
The race
So, so I'll make a comment about that and make a broader comment about it. So I do think that when it comes to, the inclusion of race in the estimation of GFR, I think that and some systems have done this, a decision can be made. I think that any change can have consequences. And so I think that where our task force is trying to be thoughtful is in making recommendations about how to do it, to try to ameliorate any sort of consequences. I think particularly in health, I think the difference between the book example that you gave with Dr. Seuss,
Sure.
compared to what we're dealing with in healthcare, is that sometimes there certainly are consequences. And I think that's going to come. As I said, our group has been working really hard for the last 6 months, actually, meeting weekly to address this issue. And so I think there will be recommendations that come. I do think that is a slither of the issue in terms of disparities in kidney disease, and that some of these other issues that I highlighted today are a much bigger piece of the challenge that I think will be even harder for us to kind of move the community on. But I'm excited that the energy I think that's being given to GFR, I hope will spill over to sort of addressing some of these other issues.
Absolutely.
So that's where I am with that.
Thank you so much.
Yeah.
Thanks, Dr. Dunn. And Dr. Churchill, thanks for popping up as well. I want to, first off, Dr. Churchill, thank you again for introducing Dr. Cruz. Again, as noted, for many years as leadership in the Department of Nephrology, you are now Associate Chair for Fellowship Medicine. Thank you so much for being with us. And then Dr. Cruz, that was amazing. Thank you for your time and going over a little bit again. As you mentioned earlier, we love having you here virtually, but we hope to have you physically come join us and I'd get to meet you in person someday in the very near future as things improve. Thank you for our panelists as always. Thank you for everybody sticking with us, and everybody have a great rest of the day.
Thank you.
Bye-bye.